Hey, this is Dr. K from iMedicalSchool, and today let's talk about cellulitis. We will review the causes of cellulitis, the differential diagnoses, as well as the management of cellulitis. So first, we need to understand what exactly is cellulitis. Cellulitis is an infection that involves the skin and soft tissues. The parts of the skin that are involved include the dermis as well as the subcutaneous tissues. In addition to an infection of the tissue, an abscess may be present. An abscess is a walled-off collection of pus that is generally resistant to antibiotics unless they are incised and drained. Now, what organisms are commonly responsible for causing cellulitis? Well, remember that your skin is the first line of defense for pathogens that lie on top of your skin. When you have breaks in your skin from cuts or trauma, bacteria are able to enter into the deeper layers of the tissue. As a result, the most common organisms involved in cellulitis are really the organisms that are constantly present on your skin. These organisms include beta-hemolytic strep and Staphylococcus aureus. More recently, methicillin-resistant Staphylococcus aureus, otherwise known as MRSA, has become more prevalent within the community and should especially be considered when an abscess is present. Now, besides cellulitis, there are other skin infections that can appear similar to cellulitis. One that we will talk about is called Erysipelas. Erysipelas is a superficial cellulitis that has a defined raised border, which is key. Erysipelas is caused by the bacteria beta-hemolytic streptococcus. The reason it's important to differentiate erysipelas from cellulitis is that the antibiotics used are slightly different because in erysipelas, we're really trying to target beta-hemolytic streptococcus. In addition to erysipelas, we should always be mindful of necrotizing infections. Necrotizing infections can lead to significant tissue and cell death. Many organisms can be responsible, but what's really scary about necrotizing infections is that they can threaten the limb, and if severe enough, require limb amputation. So it's always best to catch necrotizing infections early when all they may need is some localized debridement. Now, what are the risk factors that may predispose individuals to cellulitis? If we know what risk factors predispose people to cellulitis, we'll be better able to identify and possibly prevent cellulitis. First off, obesity is a known risk factor because it's associated with increased venous congestion and the development of greater number of skin folds, which if not properly cleaned, bacteria can grow. The presence of edema or prior radiation therapy increases your risk of cellulitis. Hospitalizations increase your risk of cellulitis and can increase your risk of developing MRSA cellulitis. If you walk down the hospital hallway, it is clear to see how many rooms are on contact isolation, either due to a patient having an MRSA infection or their skin is colonized with MRSA. Of course, intravenous drug abusers are predisposed to cellulitis because they're breaking the skin barrier many times with dirty needles and injecting bacteria into deeper tissues. Finally, the last two risk factors include being immunocompromised and being diabetic. Now, what are the keys to the physical exam? Well, it's really important to identify the areas affected by cellulitis. You really should take a marker and outline the edge of the area affected. Drawing a border will help you and other healthcare providers to see if the cellulitis is improving or worsening on their antibiotic therapy. In addition, because necrotizing infections are so severe, it's important to try to identify necrotizing fasciitis early. On physical exam, when you press on the affected area, if you feel or hear a crackling or popping sensation, this may represent subcutaneous gas produced by the infecting bacteria. If this is present, the patient would need an urgent surgical evaluation for necrotizing infectiitis. Most of the time, though, subcutaneous gas will be better appreciated on X-ray or MRI of the affected area. In addition, make sure to identify if the skin is infected with plain old cellulitis versus erysipelas with a demarcated raised border. Other considerations will be to consider if the patient has osteomyelitis. Osteomyelitis is an infection of the bone. As an infection can penetrate the skin as well as deeper tissues, they can also affect the muscle, tendons, and even the bone. Usually a significant wound is present if a patient is at risk for osteomyelitis. If the patient does have osteomyelitis, do not swab the skin to identify the bacteria involved because all the bugs of the skin flora will grow out, but rather get a bone culture performed to identify what is causing the osteomyelitis. In terms of workup, I would always start with a CBC with a differential to help identify if there's a leukocytosis with a left shift that's present. In addition, obtain an ESR and CRP. ESR is the erythrocyte sedimentation rate, and CRP is a C-reactive protein. Both these labs are indicators of inflammation within the body, but are not specific to any particular cause for the inflammation. ESR and CRP will not tell you what type of infection is occurring, but may indicate to you the severity of infection based on how high these labs are. In addition, you should follow these labs through treatment to see if there is a decrease in inflammation with antibiotic treatment to figure out if your treatment's working. Generally, I don't follow ESR and CRP, but in rare cases where for some reason it is difficult to tell if the cellulitis is improving, I may consider repeating the CRP and ESR several days after admission. Given that we want to assess the severity of the infection, it's important to obtain blood cultures, as the blood cultures will help identify a bacteremia. Bacteremia means that the bacteria have entered the blood and are causing an active infection. If a patient is bacteremic, they must be treated with IV antibiotics and not oral antibiotics. Also, consider imaging if it needs to be performed. Imaging studies can help you identify necrotizing infections. And if you are suspecting osteomyelitis, make sure to obtain a bone culture and not just a skin culture. Now let's talk about the treatment of cellulitis. Cellulitis can be treated on an outpatient basis if not severe. The key finding that dictates treatment is whether the cellulitis is purulent, producing pus, or not, non-purulent. If the area affected is purulent, there's a concern for MRSA, so think about using clindamycin or trimethoprim sulfamethoxazole, otherwise known as Bactrim. If the patient is penicillin allergic, you can consider doxycycline. Linezolid is another outpatient agent that can be used that would also cover MRSA. If the cellulitis is non-purulent, then consider cephalexin, dicloxacillin, or clindamycin. These antibiotics are mainly pointed at streptococcus. Finally, let's talk about inpatient treatment. In the inpatient setting, for patients that are very sick, I would consider starting the patient on vancomycin, as it will cover all your gram-positive organisms as well as MRSA. Now, if someone has a chronic diabetic wound, consider adding anti-pseudomonal coverage, so you could consider an antibiotic like piperacillin tazobactam, otherwise known as Zosyn. Always remember the key rules: tailor antibiotics based on the culture data to decrease the risk of developing resistance by the bacteria and your patient from developing complications of the antibiotics. Eventually, you should be able to wean to oral medications after significant improvement. Well, that's a brief review of cellulitis. I hope you liked this video. If you did like this video, make sure to share this video with your friends on Facebook and Twitter. Please give this video a like. If you have any questions or suggestions for any future videos, place them down below. And most importantly, subscribe. This is Dr. K, and I'll see you next time.